You swing your leg out of the car, put your foot on the pavement, and something deep catches. It sits in the groin and slides down the front of the thigh toward the knee, and when asked to point to it, you cannot. You cup your hand around the side of the hip instead, thumb into the crease, fingers behind. We call that the C sign. When a patient makes that shape unprompted, the hip joint itself goes to the top of my list. A strong clue, not a diagnosis, and everything that follows is me testing it. By the end of a shift, you are limping and pretending you are not. My name is Gurpreet Padda. I have treated this for 20 years. I will tell you what an image-guided injection into that joint does, what the evidence shows, and where it stops. Groin and thigh pain gets read as a back problem because the low lumbar nerve roots refer into exactly that territory. The lumbar MRI gets ordered, and in an adult over 50, it is almost never clean. A disc gets circled, an epidural gets scheduled, nothing changes, nothing was wrong there. Or the hip film is taken, the joint space is narrowed, and the patient is told to come back when it is bad enough to replace. That sends people home to stop walking and lose the abductor strength recovery requires. Waiting is not a treatment plan. And when an injection is finally offered, it is often done by feel, surface landmarks, no imaging, 90 seconds. The hip is a deep ball and socket buried beneath the iliopsoas tendon, with the femoral nerve, artery, and vein just medial to your path. Steroid left in the fat outside the capsule is not a hip injection. It is a needle mark. Now the biology and how much we actually know. Hip osteoarthritis is taught as wear, as though cartilage were a brake pad you used up. That does not explain the discordance. Radiographic severity and pain severity track each other poorly. Some badly narrowed hips walk comfortably. Some modest ones cannot sleep. Laboratory work suggests the joint is not passively wearing out. It is chemically irritated. Cartilage debris shed into the joint appears to activate synovial macrophages, which are believed to release interleukin-1 beta, tumor necrosis factor alpha, and matrix metalloproteinases, a signal set that digests remaining matrix and sensitizes nerve endings in the capsule and subchondral bone. If that is right, part of what you feel is not geometry, but inflammatory signaling inside a closed compartment. That is the rationale for placing corticosteroid, usually with local anesthetic, inside the capsule, where it is thought to blunt that signaling. Much of this comes from tissue and animal work, a hypothesis, not proven human causation. I will not sell it as one. So before we inject, we answer the question the referral skipped: hip joint, lumbar spine, or something outside the hip. Greater trochanteric pain syndrome, gluteal tendinopathy more often than bursitis, hurts laterally, and when you lie on that side. Sacroiliac pain sits below the belt line, behind. Intra-articular hip pain is anterior, deep, provoked by rotation. In younger hips, labral tear and impingement, where the injection evidence is thinner than in osteoarthritis, and I say so before we book anything. And always, a vascular necrosis of the femoral head, which changes management entirely. On the table, I test internal rotation with the hip flexed, and I log roll the relaxed leg because that rotates the femoral head inside the socket and stresses almost nothing outside it. Imaging follows the examination, not the reverse. When the picture stays mixed, with both spinal and hip degeneration it usually does, the anesthetic becomes an information gathering tool. If it substantially quiets your pain while it lasts, the hip becomes the leading suspect. Using anesthetic that way is off-label, common in interventional pain medicine, not an FDA-approved indication. And a single block can be falsely positive. It helps localize. It does not prove. The hip is too deep and its neighbors too important to inject blind. A 2016 systematic review and meta-analysis by Hober and colleagues in the British Journal of Sports Medicine found needle placement accuracy of 98 to 100% with ultrasound guidance, against 72% by surface landmarks alone. Those numbers measure where the needle ended up, not whether the patient felt better. 28% of blind attempts, better than 1 in 4, put the drug outside the joint, and the confidence interval on that landmark figure is wide. So I track the needle live under ultrasound along the femoral neck into the interior capsular recess, or use fluoroscopy with a contrast test injection and watch the dye outline the joint. If it does not spread inside the capsule, the needle moves. A 2020 systematic review and meta-analysis by Zhang and colleagues in Biomed Research International pooled 12 trials of intra-articular steroid injection for hip osteoarthritis, and reported statistically significant pain reduction out to 12 weeks. Those trials mixed randomized with uncontrolled open-label studies, which inflates apparent benefit. 12 weeks is where follow-up stopped, a ceiling on what was measured, not a promise, and nothing shows. The injection slows the arthritis itself. Many patients get less, some get nothing. So who this is actually for? Adults with hip osteoarthritis visible on film who have already given activity modification, physical therapy, weight management, and analgesics an honest trial and are still not getting enough. It is not a first move. And it is not for you at all with an active infection anywhere or bleeding risk we cannot control. Bring your anticoagulant list, including what you buy over the counter. The risks are real. A flare in the first day or two, facial flushing, a temporary rise in blood sugar, which matters if you are diabetic, thinning of skin or fat at the site, bleeding, fainting, rarely infection inside the joint, with fluoroscopy, contrast reaction, and radiation exposure. Repeated steroid can suppress adrenal output, and repeated corticosteroid or intra-articular anesthetic raises concern for cartilage toxicity. Between that concern and the cumulative steroid load, we cap these at roughly 3 to 4 per joint per year, a convention, not a validated threshold. A 2023 systematic review and meta-analysis by Sabatini and colleagues in Arthroplasty Today pooled a 6% incidence of rapidly progressive osteoarthritis after hip corticosteroid injection, with the author's caveats intact, true incidence unknown, many cases not severe, causation not established. Femoral head collapse appears in case reports only, with no reliable rate. If a hip replacement is scheduled within about 3 months, we defer, out of concern about infection around a new implant. Tell us the date. Here is one plausible course, and I have not made it the best one. What I am about to describe is a composite, a picture assembled from many patients with this condition, not one person's chart. Groin and front of thigh pain for 2 years. 2 lumbar epidurals that did nothing because the spine was never the source. Internal rotation was profoundly limited, and log rolling the leg reproduced the exact pain. Radiographs showed joint space loss. We placed the needle under ultrasound into the anterior recess and injected anesthetic with corticosteroid. Within 20 minutes, pain present for 2 years was measurably quieter. That did not prove the hip touch. A single block can read falsely positive, but with the exam and the film, it became the leading suspect. Then the honest part. Day 2 was worse, a post-injection flare we had warned about. Real relief began around day 4. It held about 6 weeks, then faded. Many patients get less than that. Some get nothing, and I cannot tell you in advance which you will be. During those weeks, we did the work the window exists for: abductor strengthening, gait retraining, load management, weight reduction, and I will name the limit. No controlled trial shows that ketogenic eating, an omega-3 pro-resolving mediator, or a red light panel changes hip cartilage, joint space width, or a hip pain score. Here they support the rehab and the weight target inside the window. They are not treatment for the arthritis, and I will not stage them as if they were. The injection did not cure the arthritis. Nothing injected does. It bought a quiet window, and what the patient did inside it changed the year. If deep groin pain is dictating how you get out of a chair, get the question answered properly. Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100, in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. The full explanation is on the hip joint injection page at painmd.tv. Bring your imaging and expect a real answer. If something in this changed how you understand your own pain, that was the point. Bring us your imaging, your history, and your questions. Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. Everything in this video is education, not medical advice. Ask for the diagnosis before you accept the procedure.